Greetings. Welcome to Enhanced Pediatric Learning. Module 1, Class 4 deals with neonatal malformations. The learning objectives of this session are to list the antenatally detected malformations, a proper visual examination for visible birth defects at the time of delivery, and subsequent anticipated management of these congenital malformations. Prior to proceeding with how to define a malformation, it is an aberration of morphogenesis where the normal tissue formation is affected. Apart from malformation, other problems that can affect morphogenesis are a deformation, which is a mechanical force on normal tissue, a breakdown of normal tissue, which is disruption, and abnormal organization leading to dysplasia. Examination of disparate defects is guided by a proper, the exhaustive, comprehensive newborn screening method given by the RBSK program, which tells us to systematically approach a neonate in assessing for visual defects. The neonate following delivery is assessed based on general appearance, the anthropometry, and overall movement and tone. The skin is examined for pallor, jaundice, or plethora. The head and face are assessed for the fontanelle as well as any features as to of dysmorphism. The eyes assessed for cataract and red reflex to see for any stigmata of congenital intrauterine infections. Mouth is assessed for proper cleft lip and palate, which has implications in feeding and initiation of breastfeeding. The chest is looked for any signs of respiratory distress and auscultated for murmur as well. Abdomen for any palpable mass, and the femoral pulses for any evidence suggestive of coarctation of aorta. The genitalia for any ambiguity, and the anorectal anus perineal examination for anorectal malformations. The back for midline defects such as neurotube defects, and the lower limbs for different limb deformities. The examination of the hip for evidence suggestive of developmental dysplasia of the hip. And in the upper limb, evidence of any chromosomal abnormality such as trisomy 21, which can manifest with a simian release. The scope of anomaly scan has quite expanded and leads to early detection of certain malformations involving these various systems. Some of these malformations can be detected quite early, and the probability of the need for termination can be discussed if warranted. And early detection helps us in monitoring the malformation such that post-surgical management could be optimized. Henceforth, we shall see a token malformation belonging to each system which needs certain neonatal intervention. We start with the central nervous system with neurotube defects, which, as the name suggests, is an aberration in the closure, with the most severe form of craniorachis and anencephaly, which are not compatible with life, and the other closed defects such as spina bifida occulta, meningocele, and myelomeningocele. It is important to distinguish to the open defects, which needs intervention in the newborn period, such as the myelomeningocele and the meningocele. Management is that of the immediate care of open defects, involvement of the surgical team, as well as avoidance of latex to prevent early sensitization, which is associated with neurotube. The initial management of an open defect is to ensure that the lesion remains moist and unruptured, such that infection seeding does not occur, and to keep it clean prior to surgical management. This involves making a plastic ring which is sterile and keeping it surrounding the lesion, and by drip irrigating it with normal saline to keep it moist and to prevent and to create a barrier for infection as well. Subsequently, we'll discuss on cleft lip and palate, which is a very common isolated malformation, though there is syndromic association with certain trisomies and the DiGeorge as velofacial insufficiency syndrome as well. Teratogenicity is seen with alcohol intake, phenytoin, and maternal diabetes. And the most important problem is that of feeding difficulties, which occur in cleft lip and palate. As we all know, it is a problem of the aberration and fusion of the mandibular and maxillary prominences, which are part of the first pharyngeal arch. Though classification is easy to identify them, type 1 is that of the soft palate alone, type 2 is that of the hard palate, type 3 is that of unilateral lip and palate, and type 4 is that of bilateral lip and palate. A practical classification of LASAL is also frequently used by clinicians. The most important problem is that of feeding, and we have to ensure that the mother is clearly instructed to feed in a erect position, either by keeping them in a sitting position or following the modified footboard hold position so that aspiration is avoided. There is increased aerophagia due to the vilopharyngeal insufficiency present in these neonates, and modified breastfeeding is recommended so that nutrition optimization and the baby is fit for surgery at the dedicated interval for intervention. Other objects used to aid in feeding the baby with cleft lip and cleft palate are the long paladay or the long spoon, the Haberman feeder, and the Mead-Johnson cleft palate bottom. Evidence is not supportive of an obturator, but if it helps to gain weight and make the baby ready for surgery, it can be also attempted. Esophageal atresia and tracheoesophageal fistula are malformations of the foregut. Its incidence is about 1 in 3,500 and mostly sporadic. Certain syndromic associations are present with Bacterial, DeGeorge, trisomies, Fanconi's, and charge syndromes. We all are aware of the Gross classification. This is the extensive Clute classification of 1976, in which Gross A is pure esophageal atresia, Gross B is that of a proximal anastomosis, Gross C, which is the most common type, which is proximal pouch and distal anastomosis, and Gross D is anastomosis at both levels, and Gross E, which is the H-type fistula. In this index case, you can see the coiling of the OG tube in the upper part of the thorax and minimal to absent gas shadow. Antenatally, this baby had polyhydramnios and absent stomach bubble gas. So this could probably be a gross type A or a gross type D. This is the classical type C, in which there is gas present and coiling could be demonstrated on the upper thorax X-ray. Routine resuscitation needs to be done for such cases. Early diagnosis leading to early surgical intervention is mandatory, especially with on a coexisting respiratory dystроsis, which can lead to gastric perforation. We want to prevent aspiration by using a modified Replogger tube to drain the secretions which collect in the proximal pouch. Next, we shall see on congenital diaphragmatic hernia, which is the improper fusion of the puroperitoneal fold with the septum transversal. Antenatally, the size of the lungs are measured in relation to that of the head circumference, and lower LHR ratios are suggestive of poor prognosis. The other prognostic factors are that of a low lung volume, the presence of liver in the chest, a large defect, severe respiratory failure, ventricular dysfunction, and severe pulmonary hypertension. LV hyperplasia with the vascular changes contribute to the pulmonary hypertension, and decreased bronchial branching with fewer alveoli because leads to the lung hypoplasia in CDH. And important factors to remember is to avoid bag and mask ventilation in the delivery room, the use of low volume targeted conventional ventilation with permissive hypercapnia, anticipation and management of persistent pulmonary hypertension with adequate sedation and analgesia. Next, we shall see on abdominal defects. It is important to distinguish gastroschisis from omphalocele. In gastroschisis, the defect is to the right of the umbilical cord, with the contents being predominantly that of bowel. Bowel atresia is the determining factor for the prognosis of this lesion, and they usually don't have any other associated anomalies. Whereas in an omphalocele, the defect is seen as part of the umbilical cord, and the contents could include liver. And this is mostly associated with other anomalies, and the prognosis depends on the associated anomalies. We will discuss on congenital anomalies of the kidneys and urinary tract as part of the renal system. The overall incidence is around 2%, with almost one-fourth of all birth defects involved being that of the renal system. Often the most common manifestation of an abdominal mass in a neonate is in hydronephrosis. One needs to know the normal values of the anterior posterior renal pelvis diameter, which is 4, 7, and 10 millimeters at the second trimester, third trimester, and the postnatal age, respectively. In the antenatal period, any AP-RPD more than 4 in the second trimester or more than 7 to up to 10 in the third trimester with only central or calyceal dilatation is UTD A1, which is low risk, meaning that repeat monitoring could be done at 32 to 34 weeks of gestation with subsequent postnatal monitoring. If it is more than 7 millimeters in the second trimester or more than 10 millimeters in the third trimester, with features suggestive of lower uterine tract obstruction with unexplained oligohydramnios, it is increased risk of A2 to 3, warranting more frequent monitoring. In the postnatal period, UTD A1 can be diagnosed as AP-RPD of 10 to less than 15 with only central calyceal dilatation, which is UTD P1, which requires a repeat monitoring of ultrasound at 4 to 6 weeks of age without any further indication. And if it is more than 15 millimeters with uterus are abnormal, it needs more frequent monitoring. And if a suspicion of a lesion warranting a maturity cystorethogram, then antibiotic prophylaxis needs to be initiated. In the most severe case of more than 15 millimeters with evidence of obstruction, and a possibility, especially in a male baby with a bilateral HDUN, then a possibility of PUV is very highly likely, which warrants immediate postnatal ultrasound and MCU and surgical intervention, such as a code knife fulguration of the lesion is warranted. Anorectal malformations as an incidence of 1 in 4,000 to 5,000. There is slight predominance in male. The practical classification is easy to use based on the surgical management. Among males, a token example of a perineal fistula, whereas this is a recto urethral fistula, a type of ARM in male. In females, this is an example of a recto vestibular fistula. Normally, it should occur at the level of the sphincter muscles. You see it's anteriorly displaced. And here it's a case of a common cloaca, which is formed by the vagina, the urethra, as well as the rectum. In evaluating a neonate with anorectal malformation, we do the cross-table posterolateral, in which the neonate is placed prone to allow the gas shadow to accumulate, and the X-ray is taken in a lateral fashion. The evidence of a gas shadow below the level of the coccyx could dictate the need for only a primary repair, whereas if it's below, it's above the level of coccyx, then the possible surgery could be that of a colostomy with further surgical revision in the future. In males, after an proper inspection, evaluation of any associated anomalies, a simple lesion could lead to a primary repair, which is an angioplasty, whereas if it's a lesion with the gas shadow quite high, then a colostomy with subsequent revision in future. In females, apart from the other associated malformations, simple lesions such as a perineal fistula or a vestibular fistula can be managed with only angioplasty or a primary repair, whereas other lesions warrant a colostomy with subsequent revision in the future. The risk factors for developmental dysplasia of hip are the 3 Fs: female, firstborn, and family history with breech presentation. The practice of improper swaddling with the legs extended and adducted is also a known risk factor. There should be enough room for the free flexion of the lower limbs. Clinical signs in DDH are the Ortolani and Barlow's test. In Ortolani, you reduce a dislocated hip, and in Barlow, you try to displace the hip from the acetabulum with an audible clunk sound. Radiological assessment is via the measurement of the graph angle formed by the intersection of these lines as denoted by these anatomical landmarks. The alpha angle should move more than 60 degrees and the beta angle should be less than 55 degrees. The alpha angle determines the type and the beta angle determines the subtype of the DDH. The treatment is that of a Pavlik's harness as a conservative management. Historically, triple diaper is now not in use due to lack of any evidence. A brief mention on the foot deformities. The two types of varus presentation in the foot are the congenital talipes equinovarus, aka the clubfoot, and the metatarsus adductus. The valgus deformity is formed by the angle between that of the axis of the foot and the axis of the leg. Calcaneovagus is a very common abnormality. It could be associated with DDH, and the vertical talus syndrome, which is essentially the rocker bottom feet, which can be seen in certain aneuploidies as well as distal arthrogryposis. Take-home messages are a good review in antenatal period helps us to monitor and to prepare for the anticipated management in postnatal period. A proper examination can lead to the identification of visual defects after birth and the need to follow established protocols for the anticipated management of these malformations. Suggested readings are Essential of Neonatology, Cloherty, the CNS Manual, Nelson, as well as Smith's Recognizable Patterns of Human Malformation. Thank you.